That sound okay? Yep. Okay. You're in the you're in the jail. In the jail. The jail building. Yeah, that's right. That's right. All right, it's 6:30, right on the money, so we'll get started. And appreciate everybody coming out tonight. Um, we're doing tonight doing allergic emergencies as we come into spring. I think the next talk is in May. Will be a new talk in the series. Will be diabetic emergencies. I think that's the second or third Thursday of May. So tonight we're going to talk about allergic reactions, bee stings, and venomations, things like that. The first, interestingly, first recorded death from a bee sting was medieval ages, if you will. In 2640, one of the pharaohs died of a wasp sting. And it was really in the early 1900s that the term anaphylaxis came about. Ana being against and phylax being man, anaphylaxis of reactions against man. And we know that somewhere around 20% of the population in this country has allergies. Now, those might be very mild, something just as common we all have living here in North Carolina of pollen or dust where you get the itchy, watery eyes and the runny nose. But there are just less than 1,000 people a year that die from true allergic reactions. And most of those are summertime, and most of them are due to stings. So the whole process of allergic reactions is very, very complex. But as a generalization, you have to be exposed to something at least once before you have a reaction to it the next time. And that, again, is a generalization, but you're not allergic to penicillin if you've never taken penicillin. If you've never been stung by a bee, you're not going to have an allergic reaction to a bee sting. And conversely, you can be stung by a bee 100 times, not have any problems, and the 101st, you break out in hives or you get shortness of breath. We do know that there's a family tendency of allergies. So people that have had allergies, when someone comes in and says, hey, you know, my mom, my sister are allergic to, boom, 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 it's something that we have to listen to because there does tend to be familial tendencies toward with allergic disorders. So what happens is the body recognizes a foreign substance. And when that happens, we're going to talk about different allergic mediators are released. And then the body starts forming antibodies, so the next time it sees that same substance, it can fight it. That's the way we build up immunity to viruses and bacteria and so forth. But there's lots of different chemicals, if you will, that are released in the body, mediators of allergic reactions, and histamine is the leader of the group, and it's the one that we really focus on. So when we talk about histamine and what we call an allergic stew, histamine causes a lot of problems. It can cause increased mucus production in the airway. So let's say that we get exposed to something that we're allergic to, whether it be an antibiotic or a bee sting or whatever. We can get constriction of the smooth muscles of the coronary arteries. We get chest pain. We can get dilation of the peripheral vessels, vasodilation, drop in blood pressure. We get capillary leakage, which causes the red skin and the itching. You get increased mucus production, so all of a sudden you're coughing, you're wheezing, you got bronchospasm. And the other thing is that there's something called chemotaxis, where the body really focuses on whatever that area of the insult is, whether it's a latex exposure or a bee sting, and it moves different agents, one of which is white blood cells, to that area, which increases inflammation. So it's a really, really complex reaction, and the worst reactions are the ones that happen quickly. So when you talk about allergic reactions and people having an onset of symptoms, really the gauge, and particularly for you guys, is how quick are things going south. You know, someone got stung by a bee 6 hours ago, now they're starting to itch a little bit. Okay, I get it. On the other hand, landscaper out here gets stung by a couple bees, and within seconds or minutes starts having itching and then wheezing and feels like his throat's closing. That's a guy that's headed for trouble. And so you really gauge the potential severity of how quickly things start. And there typically are two reactions. It's called a biphasic reaction, where you have the immediate reaction right now, and then in somewhere between 1 and 12 hours, you'll get a second reaction. And when we treat, we're treating the immediate reaction with epi. Why we're giving steroids and why we're giving Benadryl is really for down the road several hours. So biphasic reaction, reaction now, reaction in hours. And the severity of the reaction obviously depends on the antigen load, how much you're exposed to, the route of exposure, the rate of exposure. All those things play in. So we talk about how allergies manifest themselves. What's it look like? Urticaria is kind of the mildest form of what we see. That's hives. And I think we've all had them at one form or another. When someone comes into an emergency department, comes into our clinic, and they have hives, 9 times out of 10, we don't know what caused them. You go through this whole list, say, hey, did you change laundry detergents? Did you do this? Did you do that? Did you take any medicines? And no. Did you do anything different? 9 times out of 10, we don't know what caused that. It's easy to treat, but it's tough to figure out. But it's the mildest form of allergic reaction. You get these hives, you get these blotchy places. What that is capillaries are leaking beneath the skin. That's causing that red swelling and blotching. It itches. It involves the upper levels of the skin, the superficial dermis. About 20% of the population have had this. I think most of us have experienced it at one time or another. The next stage is angioedema. And that involves the deeper layers, and that's where you actually get some swelling. And these folks actually will get nausea because they're getting swelling of the gut. So you had an exposure to something that you're allergic to, and you start getting the wheals. It may involve the joints. You get swelling of the soft or the bowel. That causes abdominal pain, causes nausea. What we worry about, particularly in our business, is the swelling that comes with the upper airway. These are the folks that come in and say, I'm having trouble swallowing, or I feel like I'm having trouble, getting a little breath, or you may hear a little stridor. And that's when you worry about airway compromise, which obviously can be fatal. True anaphylaxis is a multi-system problem. It not only involves, as we've been talking about, mostly the skin, but true anaphylaxis involves virtually every organ system. You get low blood pressure, you get hypotension and shock. Vessels dilate. Basically, there's not enough fluid to fill the vessel. Blood pressure drops. You get bronchoconstriction. You get the mucus production. So you get the wheezing. You can get upper airway obstruction. And as you get the hypotension, you talk about what causes death in true anaphylaxis. It's airway obstruction and hypotension. So when we talk about shock, hypotension, the different types of shock, we're talking about a distributive shock. And we've been through this lecture before, but of the distributive shocks, septic, neurogenic, anaphylactic, where sepsis is overwhelming infection, vessels dilate, not enough volume to fill the vessels, blood pressure drops. Neurogenic, knock out the sympathetic nervous system. Same thing, vessels dilate, they won't constrict with stress. Anaphylactic shock is due to the antigen antibody release. And so you go through, you get the red skin, you get the hives, you get the itching, but then you get vascular dilation, so you get drop in blood pressure. And along with that, then you expect an increased heart rate. That patient's anxious because they're not perfusing. Now they're wheezing, they're short of breath. And those are the things that you see in distributive shock. Distributive shock, again, is there's just not enough fluid to fill the vessel. It's not like we've lost fluids. They're there. The vessel got bigger. So when we talk about symptoms of allergic reactions and of shock, itching, hives, urticaria, hives, and swelling are virtually present 9 out of 10 times. That's the most common thing. People get wheezing. They get short of breath. Upper airway swelling half the time. Down to simple stuff like simply runny nose, itchy, watery eyes. So what causes? We've talked about some of the way that what's this look like. There are lots of causes, and we're all exposed to different stuff at different times. Drugs are an offender, particularly antibiotics and many of the non-steroidal class of drugs. And what are non-steroidals? Those in Motrin, Aleve, that class of drugs. A lot of foods have come on play, particularly in the last 20 years, peanuts being a big one. Shellfish allergies, people that can't eat certain types of seafood, particularly shrimp, lobster, the shellfish. Eggs are a pretty common allergy. That's why we ask you every year when you're getting a flu shot if you're allergic to eggs, the protein in the egg that you're allergic to. Pollens are in inhaled allergens. We work with an industrial client in Franklin County who everybody in that plant, they're making enzymes, so they're exposed. They have protection, but they're exposed on a daily basis to proteins which they can inhale. And about 1 or 2 of these people a year develop asthma. That's an environmental cause. They've been exposed to it, and all of a sudden they develop a sensitivity to it. Lots of soaps and lotions. We're going to talk about bee stings in a minute. Not as much the snake bite as the snake antivenom in the past has been the thing that causes allergies. And then the thing that we're seeing more and more of all the time, and we are all at risk for our latex allergies. So we talk about this time of year, and we talk about allergic reactions. The thing that we have to be concerned about are envenomations. When we talk about envenomations, primarily around here, we're talking about stings. And this causes it's not unusual to see an allergic reaction. Fortunately, there's somewhere less than 100 deaths a year from envenomations and stings. But most of these are from the class of bees called Hymenoptera, which are your wasp, bees, and fire ants. And these guys cause reactions in 1 to 3 out of every 100 people. What's interesting here, as I said, we've all been stung. It hurts, and we probably don't have much of a reaction. But when you do have reactions, say for the first time you get stung by a bee, and not only do you hurt at the site, but say you develop hives within, half hour, an hour, whatever it is. You get over that. But the take home there is that you've got somewhere between a 3 and 6 out of 10 chance, 35 to 60% chance, that the next time you get stung, you'll have true anaphylaxis. So that's what's important that we tell all of our patients is that, yeah, you got stung today and you had this reaction, but the next time you get stung, it could be a life-threatening event. And there's no way of predicting that. But half the time it will be, and that's why these people go out with prescriptions for EpiPens, which, of course, the big deal last winter was the EpiPens went from $100, $200 to $600 or $700 or whatever it was. Craziness. But those folks who have these reactions have got to carry them. So we talk about envenomations, mostly being bee stings, the Hymenoptera class. Hymenoptera are critters with winged membrane wings, and that includes honeybees, bumblebees, yellow jackets, hornets, wasps. Interestingly, includes fire ants, and the people that are most susceptible to these injuries are typically kids and the elderly who can't get away from them. They either get exposed to them and they can't run fast enough, or they've messed around and somehow ticked off the bees. So honeybees are one of the few insects that have been domesticated. And what do you mean domesticated? You know, they're not trained, but they're used for domestic purposes, you know, with beekeepers and hives and honey production. But a honeybee, they're generally not terribly aggressive. The small bees, you know, kind of black and yellow, look furry. What's interesting about them is the way they sting. Now, a cousin of them are the Africanized honeybees. Unfortunately, we don't have them here. The honeybees, the domesticated, are in hives, and otherwise they tend to nest in hollow trees and places like that. But the variant of the honeybees came from South America, the Africanized version, and they tend to attack in great numbers. So in other words, instead of a honeybee being one of them that attacks you, these guys swarm, and they'll actually follow prey half mile. And you'll hear the stories of people trying to run from these things and jumping in the water. And the problem with them is just the sheer number of stings delivered. Remember, we talked a little bit ago about allergic reactions being the rate and the route and how much antigen you get exposed to. Well, a honeybee delivers a small amount of antigen. These guys, so 200 of them get on you and sting you, that's a lot more venom. And so this is a number of one. They're very, very aggressive, and it's the sheer number of stings because they tend to follow their prey. They swarm several times a year when they produce new queens, and they tend to colonize in remote areas. So again, fortunately, they don't put up with weather like this. So while we've got them in the southwest and somewhat in the southeast, we don't have them in this part of the country. But there have been several cases reported of deaths with mass stings in this country. So fortunately, they're not here. Bumblebees are those big old slow-moving, noisy. They live in the ground. They're pretty non-aggressive. You know, their use is in agriculture. They do. When you go to, for instance, Napa Valley in the wine country, they're counting on the bees. They put flowers at the end of the vineyard so that they're cross-pollinating, get all this different stuff done. That's what they're counting on the bees to do. But these guys are not a big issue. Wasps are problematic. Nobody likes wasps. They live around the house. They build those little paper-looking nests. They're in hidden places where you never see them until you sit down on a chair and they're underneath of it. But they're very, very aggressive is the problem. And they actually attack when you get into their neighborhood. Yellow jackets in the ground. These are the ones, particularly late summer. You go to a Dairy Queen, there's a big old garbage can out there with all kinds of sweet stuff in it, and there's bees. Those are yellow jackets typically. They're the ones that live in the ground. Again, they're very aggressive, and if you get into a colony of them, there are several hundred to several thousand. You can get multiple stings out of them. And hornets are the ones that live in the trees. We all threw rocks at the thing and then ran. Probably not fast enough, because there's a lot of bees in that hive, and they will swarm and come after you, and you can get multiple stings from them. So honeybees, the interesting part is they sting you once. You know, they're the kamikaze. When they sting, they're done. And it's because their stinger is attached anatomically in their abdomen to their bowels. So when they sting you, that if you look microscopically at that stinger, it looks like a little fish hook. It's got little barbs on it. And it gets in the skin, and there's a little venom sac at the top of it, and it keeps trying to penetrate the skin. And it's holding on, but the bee is dead. So that bee can sting you one time, but the stinger will continue to try to work its way into the skin. We used to say we had to get that stinger out right away. Well, now we know that probably most of the venom is injected at the first sting, but even after that bee dies, that stinger is sitting there and that venom sac is still trying to pump venom in. But it is important that when you have a honeybee sting or multiple honeybee stings, that you look with the microscope and you try to flick that stinger out of the skin and prevent any more venom from going in. What you really don't want to do is grab that venom sac with a pair of tweezers and squeeze it and pull it out. It's like removing a tick. When you squeeze the tick to pull it out, you're injecting tick parts into yourself. Same way with the venom. So the easiest way to remove these stingers is flicking them off with something, you know, at the edge of a needle and just flicking them out. But you do want to get the stinger out of the skin. The other guys, wasps, yellow jackets, hornets, they all can sting multiple times. And so their stinger is attached to them, but they can nail you repeatedly with the same stinger. And they've got a venom sac in their body that every time they sting is injecting venom. And what's interesting about the venom composition, if you look at all these, it's pretty similar. It's a bunch of proteins, and it hurts like heck because of serotonin and acetylcholine. So when it injects you, you get just an intense local pain from it because of the proteins. That's the way we tell, by the way, if snake bites. You know, if you get bit by a snake and it's a poisonous snake and you got the two holes, if it doesn't hurt, you didn't get envenomated. And only about 50% of those snakes, when they bite you, do you get an envenomation. So if you get bit by a copperhead and you've got the two holes and there's the copperhead, if it doesn't hurt, you didn't get any venom out of it, because it's like getting stung by a bee. It hurts like heck. But yeah, anyway, so these venoms are all very chemically similar in a lot of ways. And there's a lot of different antigens. And what happens is you get stung, the body recognizes this, begins getting antibodies, but the direct result is that single sting causes cells in your body, mast cells, to degranulate. You get a histamine release, and then you start getting hives and itching and trouble breathing, and worst case, you start dropping your blood pressure and palpitations. You can actually have a reaction as long as 6 hours later, but most people get just a local reaction that hurts like heck, and you get a little local redness, and that's it. That is a typical local reaction. But again, the people that are getting trouble are the ones that have severe reactions very quickly. They start getting that sensation of, I can't breathe, I got swelling in my throat. That's bad. And upper airway obstruction is the leading cause of death. So, you know, when you talk about what we do in this room is, and we'll talk about the treatment, but yeah, you're getting the treatment, but you've always got to be prepared in a case of a bad allergic reaction to do an emergency airway. And that's always a tough situation, because you're treating the patient, they're getting worse, and now they can't talk and they can't breathe. Do you try to intubate them while you still got a chance, while they're still awake, or do or you hope they turn around, and it is difficult. So airway obstruction, intractable hypotension, low blood pressure is the second leading cause of death. So you can get delayed responses to bee stings. So you get stung, you've been stung before, the antigen antibodies build immune complexes, and then over the next few days you can get a fever, headache, swollen glands, this arthritis sensation. That might be a delayed reaction to the bee stings, but ones we're focused on this evening are the acute allergic reactions that are life-threatening. When you get stung, you get a local reaction. You know, people think, okay, I'll take some Benadryl, get some ice on it, it'll be fine. But you know, that lasts 3 to 7 days, and it's painful during that time. So when we talk about the Africanized bees or the hornets, some of the ones that sting in mass, again, we're talking now about the volume of venom that you get. And once again, the very young, the very old are at risk. And it usually occurs, when you've been in the wrong place. Either you've hit that hornet's nest with the rock, or you've stumbled into, you're mowing grass and you stir up a yellow jacket nest or whatever. But it can be these mass stings with the volume load. You can get massive histamine release, so you can get the abdominal pain, you can get the nausea, you get the airway problems, and you can get multi-system organ failure, and it requires supportive care. So most of these, and almost all these cases, are survivable, but we've got to get to them. We've got to get the epi, we've got to get the fluids, we've got to sustain the airway, and if they get through that first phase, they're, in most cases, are fine. Fire ants are interesting in that they're related to bees and can cause allergic reactions. And once again, it's fortunate that they've kind of made it to the edge of our territory. When we lived in South Carolina, and if you guys have ever lived south of here, fire ants are a real nuisance. They have mounds, and you'll be walking through your yard, and all of a sudden you'll step on a soggy place, and you look down, you've got an ankle full of ants, and they're all mad at that point. What they do, which is kind of interesting, is they both bite and sting. And they've got, when you look at them microscope, they've got teeth that they bite you with and hold on while they then go kind of in a circle and sting with their back end. And they don't have the venom that a bee does, but it hurts like heck when you get stung. And then over a course of days, it's fairly classic. You get this red place that hurts where they get stung, that then develops what looks like a little pimple, a little whitehead, and then it becomes a little bit of necrotic area, just a little tiny ulceration. So they can sting you multiple times, and you can have allergic reactions to them as well. But they bite, and they kind of rotate around that bite, stinging you multiple times. And the problem with fire ants is that if you step into a fire ant mound, you're going to have multiple of these guys stinging. They get pretty uncomfortable, and people break out in hives from them and get pretty miserable. So when we talk about reactions and classifications, you get the local reaction, mild, moderate, severe, systemic, toxic, and delayed allergic. We're not going to talk much about the delayed allergic reaction. But when we talk about local reaction, this is fairly typical. You get stung, it hurts, the pain's very localized, the itching's localized, the redness is localized, and we're talking about somewhere that's, a couple, 3 centimeters across, and it's warm to touch. And that's going to persist over a period of 3 to 7 days, and that is a typical local reaction. You can tell people, no, you didn't have an allergic reaction. That is completely expected. And what do we do about that? Well, when it happens, ice, cool compresses are about the best thing. Take some Benadryl, Atarax, hydroxyzine's okay. It's prescription, but basically it's a histamine blocker. You can add. Remember, when we talk about histamine blockers, there's H1 and H2 receptors. H1 is the Benadryl. H2 receptors are things, H2 blockers like Pepcid, Zantac, the old Tagamet, stuff like that. And so we actually give both now. Benadryl, of course, causes you to be sleepy because it crosses the blood-brain barrier, but they all work to prevent itching or to help itching. And sometimes these local reactions will get a little topical steroid or even some oral prednisone. But again, local, last a few days, they're gone. Mild reactions, so you get stung and it hurts, and now all of a sudden you get this kind of warm feeling all over, and you get some itching away from the site. You get the hives. What do we do with that? Again, cool compresses. We get them on antihistamines. Most of these people end up with a case of oral steroids. The moderate reactions, the ones that we get involved in more so. And that's where, let's say it's again a bee sting, patient gets weak, they don't feel well, they get that feeling of tightness in their throat because it's a multi-system problem. They're getting some edema in the gut that causes nausea, and they get generalized swelling. And these are the guys you've got to watch because, again, when you look at them, someone's got hives all over and they talk about throat tightening. You want to look in their mouth and you want to see what the soft tissues want to look like. You want to listen to their airways for stridor. You want to listen for wheezing in their lungs. But these are the ones that I would right away go to Epi-IM. And they'll get IV steroids, and they'll get Benadryl, and they'll get Pepsid, and they'll get an IV established. But I can't emphasize enough, when someone has an allergic reaction, they've been exposed to an allergen, and they start talking about they feel like their throat's closing, take it seriously. This is one of the cases where no one's going to fault you for being aggressive and seemingly over-treating, because the option is, if you under-treat and you don't take them seriously, things can go south in a hurry. And so when we've listed the treatments up here, it's out of order. You go to Epi first, and then you can get your IV established, and you can give them Benadryl, you give them H2 blockers, and give them steroids. But if you're talking about those four things, the Epi is going to work right now. The steroids are going to work in 1 to 6 hours. The Benadryl is going to work in 1 to 6 hours. The H2 blockers, likewise, they're working to prevent that second reaction. You're working with the Epi to take care of the situation right now. And then severe reactions are those that have an exposure and they develop wheezing. They might have the stridor. Has anybody ever heard real stridor? You know, it's like, I can't even mimic it. It hurts my throat. You know, they're breathing in. You just hear this high-pitched, terrible sound. And it's coming because the wheezing comes from the lungs. It comes from bronchospasm and mucus production, and the air is moving in and out of these small airways, and it's causing noise when it does. Stridor is coming from a large upper airway, which is narrowed. It's trying to pass air through a very, like a whistle. And so a severe reaction, if you've got someone with stridor, those are the ones where you've got to jump on and you've got to be ready to be in a position to cut a throat. These guys may be hoarse, they're short of breath, low blood pressures, and of course with low blood pressure they're going to be tachycardic, and they can really get in trouble fast and go into complete cardiovascular collapse. So what do we do with severe reactions? Again, Epi first, and these are the ones where you may give, you know, I've given IV Epi 3 times in my career. All 3 times the patient had VTAC. But these are the ones where we get the Epi on board quick. You repeat it in 5 minutes, get an IV established, give them fluids, give them steroids, start inhaled agents, albuterol for bronchospasm, and treat very, very aggressively. Drugs can cause allergic reactions, and the penicillins are the ones that are most complicit, if you will. And penicillins, if you talk about of all the deaths from allergic reactions to drugs, penicillins cause 3/4 of them. And, you know, that's only about 100 deaths a year. There's something like 7 or 8 million exposures a year. What's interesting about penicillin is there are rarely, almost no deaths from taking it by mouth. 6 recorded cases. All the cases of deaths and allergic reactions to penicillin are primarily IM injections. The old case where you went in, you got a buttload of penicillin from your doc. And those are the patients that reacted. So there's some cross-reactivity. We talk about penicillin, cephalosporins. Cephalosporins are the class of Keflex, Omnicef, Cefdinir for those with kids who've had ear infections, injectables, things like Rocephin. So your cephalosporins are first, second, third, now fourth generation. But in the early days, when those drugs came on market, there was somewhere around a 5% cross-reactivity. You look at the chemical structure, there's a couple differences on one of the side chains that make cephalosporins different. So there was some cross-reactivity. Today, we ask people, say, are you allergic to penicillins? Yeah. What happens? I ended up on a ventilator from it. All right, that patient's not going to get a cephalosporin from me. On the other hand, it's like, I had some nausea, I had a little skin rash. They're 99.99% of the time, they're going to do fine. with a cephalosporin, and we'll give those patients IV Rocephin, safely. But you look at what was the reaction with penicillins and then kind of temper that with what you're going to do. And so you get restricted from cephalosporins if you had a severe life-threatening reaction to penicillins. Aspirins, nonsteroidal drugs, and this is interesting the way they work. Nonsteroidals block a certain pathway. They block inflammatory mediators. So there's two pathways, and so Motrin blocks this pathway here. Well, that means all the other materials are going down the other pathway, and so some patients take nonsteroidals and begin wheezing. About 20% of asthmatics can't take nonsteroidals because what it does is it increases some other inflammatory mediators. They get bronchospasm and they get wheezing and they may break out in a rash. So nonsteroidals are a source of problems. Aspirin can cause some. One that all of us are exposed to is latex. And latex has come big in the last 30 years. When I went through med school in the 80s, we didn't wear gloves in the anatomy lab. You didn't do that. And then all of a sudden this disease called, and it wasn't HIV, it was discovered. It's like, we started wearing gloves. And, that was the way things were 30 years ago. You didn't wear gloves for anything. You went into the ER, you had blood all over you. It's just the way it was. Well, now you wouldn't dare do that. We all wear latex gloves. And sensitivities are increasing. And they're increasing where you would expect. Nurses, surgeons, healthcare workers, people work in the rubber manufacturing industry or the glove manufacturing industry. Latex is a protein, and it comes from rubber manufacturing. So it's a rubber protein. So we've got, if you go back tonight and look on one of the units and just look at what you've got in there, it's potentially latex. It's the gloves, and it's probably some of the IV catheters and tubes, Foley catheters that we put in, tourniquets, the tourniquets you put on the arms, they're probably latex. Some of the tapes are. And these reactions can be very mild where you put a tourniquet on, take it off. Yeah, there's a little more than your constriction band. It might be a little red band. Or you wear gloves, you peel them off, you can see where the gloves were. The skin's kind of irritated and it's kind of red. We have a couple people living here in town who have true latex allergies. They get exposed to latex, they anaphylax. And so when someone tells you, hey, I've got a latex allergy, how bad is it? I anaphylax. Well, you better be using the purple gloves, and you better be checking everything else that you expose them to as well, because it can be a significant reaction. IV contrast material can cause allergic reactions, and that's not the same allergic methodology we've been talking about. These 1 to 2% of the people will have problems with IV contrast material. And most of those people will tell you they're also allergic to shellfish. So if you've got a shellfish allergy and you have to go in for a contrast CT where they're going to give you IV contrast, they really want to know what your allergies are. So you worry about people having reactions to IV contrast who are allergic to shellfish. Older, and I've said many times, we talk about increasing age. Every year I get older, that gets the higher number, but it's really 60, 65 is considered elderly. People who are dehydrated, what's going to be the dose of the contrast material? Again, rate and route. People who don't have good working kidneys can get into trouble. But generally what happens in hospitals is they determine kind of what the risk is, what the need of the test is, and if they really have to give the contrast, they'll pre-treat with steroids and Benadryl before they give it, and most of the time do fine. Food allergies, we talked a little bit about. We're seeing more and more peanuts. It's a significant enough allergy that there was a period where, airlines weren't even serving peanuts on the plane because they're afraid of someone going to anaphylax, but it usually occurs right after the ingestion. And this is something where Someone's sitting in a restaurant, they're eating, and all of a sudden they get the itching, if you will, inside their mouth, or they get this difficulty swallowing. It's a local reaction to what they just put in their mouth. And again, it's a biphasic response. You got the reaction now, and you think about it, the food goes down and it's passing through the gut and it's going to get ingested. So a few hours later, you're going to get that reaction again. It can also be due to the food allergies, but peanuts, milk, eggs are all important, and that's why kids now who have these allergies really have to be watched at school, because think about, kid goes to school or a kid goes to a birthday party or whatever, milk, eggs, peanuts, chocolate. It's just one of the things that a parent really has to keep an eye on. There's a couple of interesting variants of allergic reactions. One's Chinese restaurant syndrome. These people, and it's thought to be due to MSG. You sit down, you have a meal that's loaded with monosodium glutamate for its a flavor enhancer. All of a sudden, you get chest pain, palpitations, you get the nausea, GI symptoms, and flushing. It's very, very similar to an allergic reaction. It's treated much the same. The other one is, and this appeared on our emergency medicine boards every single time. Never seen a case, never heard of a case, but it's scromboid poisoning. It comes from bad fish, certain kinds of fish, in this case, tuna, mackerel, dolphin. Basically, the fish is not good, and there's histamine being released in the meat, a histamine-like toxin. So you eat the fish, and you get a huge dose of histamine-like toxin, and you have an allergic reaction. So, kind of the wrap-up here. 10 things to remember, and we'll go through these real quickly. Hypoxia kills. You got to treat the shock. You got to recognize the limits of treatment you've got. You got to recognize who's getting into trouble. It's a family affair. It runs in families. Remember the beta blockers. How do you prevent it? What's the self-treatment? Allergies are acquired, and be suspicious. So when we talk about hypoxia kills, you've got to watch that patient who is hoarse or has stridor, and those are the ones that scare me the worst. They walk into the clinic, or they walk in the emergency department, hey, I had this happen, I'm allergic to wasp, and I feel something tightening, and my voice isn't right. They're headed for trouble. You've got to pay attention to them. And if you're concerned at all about them having an allergic reaction, and it's a valid, everything seems valid, then they need EpiPen or Epi. They need oxygen. You've got to watch their airway. You've got to be ready to do an emergency airway. And these are the patients that you can't just tuck away in a corner somewhere in the ER and forget about, or you'll go back and find a body a few hours later. You got to treat the shock. Again, patients getting into trouble, they're tachycardic, they got low blood pressure. You got to get the Epi on board. You got the IV fluids. Everybody goes in, we always have, we've done it for years, we plop the arms out and we start putting tourniquets on. What you really need to be doing at that point is drawing up 0.3 of Epi and getting it IM, then starting the IV. Sub-Q Epi is not going to be of any use. If you got someone who has a low blood pressure, let's say they're really sick, they're 70/40, they're pale, they're diaphoretic, and you guys are on the scene, someone's setting up the IV, someone's getting ready to give the Epi, and all the other things that are going on. What happens if you give it sub-Q? That's exactly it. You're depoting it. So we go back to the shock lectures. The body starts shunning blood away from the non-essential organs. That's why your skin turns pale, is that blood's being shunted away from it. So you're not perfusing that fatty tissue. The body's trying to perfuse the heart, the brain, the kidneys, the bowel, And so you go popping in, you pull it up and you put a 0.3 of Epi in the sub-Q tissues and nothing happens. And you do it again, nothing happens. And then you get a few minutes down the road and you resuscitate them, and all of a sudden their blood pressure comes up, then what happens? Blood pressure jacks, heart rate jacks, because all of a sudden you're picking that Epi up. But the bottom line, didn't work because you were giving it somewhere it's not being absorbed. Then if you do resuscitate the patient, you've got all this Epi that depoted in there that you're going to pick up now and have this tachycardia and hypertension to deal with. So Epi-IM and sub-Q in the presence of hypotension doesn't do anybody any good. You've got to recognize the limits of the drugs you're given. We talked about this. Epi is the cornerstone of treatment. If you don't take anything else out of here tonight, Epi is the cornerstone of treatment. And it goes number one. It's what we treat acutely with. Now, Benadryl is needed, but it's not going to get the job done right off the bat. Steroids are needed. They're going to work in an hour or two. Airway's got to be protected. Give the Epi. Next thing it probably is most useful right then is albuterol. So get the Epi on, get the albuterol going for the wheezing, start working on your IV, get the steroids in, get the Benadryl in, but Epi is the cornerstone of treatment. So you've got to recognize the limits of the drugs that we've always been taught to give. The Epi is the one that's going to save a life. Who's in trouble? This is absolutely key. Those people who come in, voice changes, hoarse, stridor, short of breath. You look in their mouth and you just see all this swelling. They're headed for trouble, and you're headed for some exciting times if you don't jump on it. It's a family affair. We talked about you've got to pay attention. We pay attention to someone comes in and says, all right, you got a urinary tract infection. I'd like to treat you with a sulfa drug. Well, my mom's allergic to sulfa drugs, and my two sisters both have rashes with sulfa drugs. Okay, we're not going to treat with sulfa drugs. Never had a reaction, but things run in families. And there is this, what they call atopic history, if you will. So you've got to watch the patients. There are cases of angioedema where we just can't figure out why it is. You know, you go through all this stuff. A few years ago, they discovered the tick allergy. I think most of the research was done at Duke, where you get bit by a tick, then you can't eat red meat and stuff like that. But, you know, angioedema, we can see people that have what we call idiopathic angioedema. It's like they swell, their tongue swells, they get GI symptoms, they get itching, and it's like, what happened here? We don't know. And so there is a familial tendency toward these things. If you go tracking it down, other people in the family may have allergies as well. You know, around the beta blocker, if you're giving albuterol, for instance, if the patient's on big doses of beta blocker, they may not respond. And always remember, glucagon's a great choice if someone's on beta blockers for helping turn things around. Prevention. If you know that you're allergic to penicillin, you've got to note that in your medical chart. You've got to make sure you've got to double check your healthcare provider. You've got to make sure you don't get penicillin. If you know that you're allergic to bee stings, you don't go running barefoot through the clover when, you know, it's a nice summer evening. Something bad's going to happen. And so you've got to avoid the cause. You've got to tell your patients to avoid the cause. And they got to carry an EpiPen. Now, the problem with that is the EpiPens are so freaking expensive. And, you know, most patients, if they can't afford it, they can be taught how to carry a vial of Epi and how to draw it up and stick themselves. I mean, it's just something really simple. If you think about, you know, we do pretty well in this county, but where I live at the lake right now is 20 minutes from you guys. You know, that's a long time if you have a true anaphylaxis. And so people who have true anaphylaxis need to be carrying Epi, or they need to be carrying EpiPen, and the instruction is they should have one on them and one in their vehicle all the time. And the problem with the EpiPens, and it's like we carry in the truck, is that, you know, there's a point at which that Epi exposed to hot and cold and sunlight begins to deteriorate, and you got to replace it. Well, you know, not many people can go out and plop down $600 every couple years for a preventative medicine that they haven't used. So that whole EpiPen thing is a big, big issue for a lot of people. So prevention's key. Self-medication, EpiPen save lives. We know that. Benadryl is absolutely benign. It makes you sleepy, but it sure does work. And these are things you keep in the car, keep at work, keep at home, keep them close if you have a true reaction. We talked about this. Allergies are acquired. You know, you've got to be exposed once. You can be exposed 100 times, and the 101st, something goes haywire in your immune system, and now you've got, you know, the problem is once you switch, you're tagged as being allergic from then on. You know, the chances are that if you get stung 100 times, no problems, the next time you have hives, you're going to have hives, or you're going to have something worse there going forward. So allergies are acquired, and once you've got them, you've got to just be prepared that that's what you're dealing with. You've always got to be suspicious. You know, someone is having trouble breathing, or they have this strange sensation. You've got to ask those questions. Hey, did you eat something? Did you drink something? Did you get exposed to something? Are you allergic to this or that? And always look for urticaria and think of allergic reactions and potential shock, and try to stay ahead of it. So what do we do as far as treatment? ABCs. Maintain the airway first. Death in these cases is from airway compromise and shock. You identify the cause, treat the problem. EPI's the key. Maintain the airway. Pretty straightforward stuff. So these patients, for first responders, what do? Well, the patient needs to be sitting upright. If you've got somebody who you think, if you think about what we talked about tonight, they got stung by a bee, or they got penicillin, and all of a sudden they're wheezing and they're making a lot of mucus in their airways, the last thing we want to do is lay them down. They probably won't let you. So we want to get these people sitting up. We want to get them on oxygen. We want to get epi into them, and if they've got an EpiPen, help them use it. Early on, we want to get epi to them. We want to get albuterol. We want to look the examination, look for airway swelling and what we have to do there. But again, epi is the cornerstone of treatment. That's what I've been saying, and say it again. So for moderate to severe reactions, we give 0.3 to 0.5 of 1 to 1,000 IM. We repeat it at 5 minutes. So you give it, then you start working on all your other stuff, and at 5 minutes, if that patient's not where you want them to be, you give it again. It improves vascular tone, it improves contractility of the heart, it blocks the allergic mediators. It is the treatment that we have to use first line. Once we give the epi, then we can start talking about IVs. Get a couple IVs in. Remember, this patient, in all probability for that severe, they're in distributive shock. They've still got their 4 to 6 liters of fluid they started with, but the vessel got bigger. We need to put a couple more liters in there. So you give them 500 cc boluses at a time, up to a maximum of 2 liters. And hopefully the epi's working, and they get some vascular tone, the blood pressure comes up, the heart rate comes down, and everybody's happy. Get the stinger out if it's still there, reduce the antigen load. Once we've gone through that initial phase, give the epi, get the IV, give the aerosol. Now we can start talking about the other things. Getting the Benadryl on board, getting the steroids on board, Pepsid and Zantac on board. Those help reduce the itching. And Solumedrol is a good choice for steroids. So steroids work longer term. They stabilize cell membranes. They reduce inflammation. But what they're really doing is, in reducing inflammation, is preventing or reducing your secondary reaction. So in summary, most of these reactions, the vast majority we see, are going to be mild. The life-threatening cases require epi and Benadryl and steroids and aerosols and IV fluids. And for the first responders, thing that you can do when you get there is, if they've got an EpiPen, help them use it. Look and see which way the needle goes. People have, back the old days, the morphine injectors in the Army, I can't tell you how many people stuck needles through their thumbs because they had their thumb on the wrong end when they jabbed it down. Just make sure needle goes here. Help them use their epi, and it can be a life-saving event. Well, that's it. What questions do you have?